Janae Sharp from the Sharp Index. I was sitting down today with Heather Lavoie and wanted to talk to her specifically because she is a leader in healthcare technology. Many physicians and healthcare workers don't love their technology. So I wanted to ask her what her experience has been. Also, they've done some really significant research about physician well-being and how to improve that. So Heather, maybe you could introduce yourself to everybody. She's awesome, by the way. If you haven't met her, you should.
Thank you. It's always a pleasure to work with you, Janae. So I'm Heather Lavoie. I'm president and CEO of Genea. I've been with the organization since we founded it in 2012, and we're a healthcare analytics and data science organization, and we're really focused on improving health outcomes and as well as cost and quality in healthcare. We work with hospital systems, we work with physician practices, as well as health plan and employer organizations to drive health outcomes. And we have a strong team of data scientists who build predictive models to help anticipate disease progression, disease onset, costs, so that we can maybe intervene earlier and more readily. And so we have a particular focus on physician satisfaction, or the degree to which physicians feel miserable in their profession. So we've been surveying physicians since early on in the organization.
Yeah. And okay, so there are a lot of things I would want to talk to you about with that. I guess the first is maybe we could talk about the physician misery index and measuring that and your experiences, what they've been.
Sure. I started out in physician practice operations, and it was really right around the time when managed care was coming into play, and at the time where we were starting to pay a little bit more for quality outcomes and not just on a fee for service basis. And I worked with a number of physicians who were pretty happy in their profession at the time. And I saw, just year over year over year, sort of an erosion in satisfaction. And I think an increasing burden that physicians were expressing outside of the professional setting, but even physicians I knew on a personal level, just the burden that they were feeling in terms of documentation, sort of the reduction in time that they were able to spend with patients, and just really, I think, being a bit disillusioned with what physician practice was as compared to what they thought it was going to be when they went in. And so in 2015, we set out to do a national survey of physicians to help understand sort of the extent to which they were dissatisfied or miserable in their profession, and then what were some of the drivers of that dissatisfaction. And then we repeated the survey again in 2018 to see if things had improved, and actually it got worse over that time frame as opposed to improving. And we saw like 8 out of 10 physicians felt like the quality of time that they had with patients had decreased. More than 3/4 of them knew someone that was likely to quit medicine in the next 5 years. Nearly 3/4 were personally considering a career change. And at the time, and this was pre-COVID, about 57% of them expressed that they were personally at risk for burnout. And what was really striking, and it definitely resonated, it was something that we knew that we were feeling, was almost 100%, about 97% of them felt like they needed more time with patients, that was really critical, that they didn't have, patients were sicker, and that they didn't have enough time to talk about the challenges that patients were facing, and that if they actually had the time, they could drive better health outcomes. They also could prevent a lot of emergency room visits. They could prevent unnecessary hospitalizations, and yet they just felt like they were on the hamster wheel, and that they were glorified data entry clerks, that we were asking people, instead of working to the top of their license, to sort of work to the bottom of their license and doing a lot of just documentation that didn't drive a lot of additional value.
Yeah, they do a ton of documentation for every visit. I've talked to a lot of physicians too since the pandemic started, there have been a lot more people reaching out for mental health support or for different problems that they've had within their practice, just not really knowing how to manage that. Um, One of the things you said that was interesting was talking about like the cost of technology and that time. And what have people, I mean, you probably have a different perspective how technology can help with that, but
Mhm.
also a better understanding of the actual time burden that we're placing on physicians. I think about it, even a lot of people can think about it from a patient's perspective. You go to the doctor, you get, maybe you have a chronic condition and you get medication. As soon as you leave, it's like you don't exist anymore. And what does that do for your health? Like, do you actually follow through on it? Or do you go home, lose your prescription, and then go about your life? Um, and I think you have a great perspective from the other side. Like, what does that do? What does that mean for healthcare? And what does that mean for physicians?
Well, they certainly spend, at least as has been reported in surveys, even beyond ours, several hours every night, 2 to 3 hours a night on post-care documentation because they don't have enough time. So charting, they don't have enough time to get to it during the day, and so it's bleeding into their family time, into the evening hours, after their kids go to bed, if they have families, and they really should be able to get to it during the day. And I think the challenge is despite the fact that electronic health records have been around for a while, we really are still on a first generation of electronic health records, right? They were designed for a specific purpose, but not necessarily designed well for workflow, and as well as designed well to ensure that other members of the care team maybe could handle some of the documentation on behalf of physicians. And I've said this many times, but I started out doing transcription. And for some reason, we did away with transcriptionists and we require physicians to type their own notes because we felt that it saved time and money. And ironically, if a physician could dictate their notes, all of that translation could be done outside of the visit by someone else. Certainly, I made a lot less at 17 years of age, a lot less than a physician made, and so it seemed like we were being penny wise and pound foolish, and so we're requiring doctors to type all of their own notes, to do all of their own coding, make sure they're getting the coding correctly. And so when we've designed our systems at Genea, we've designed them in such a way to provide tools and resources for other members of the care team. So the physician should be the quarterback. The physician doesn't need to be every player. And so if there's coding, missing codes or suspect codes that we can surface up to another care team member, they could take care of those. If there's gaps in care, we can provide that out again to a medical assistant or nurse. We can provide a lot of information so that pre-visit planning can be handled before someone even comes into the visit. Documentation can be provided even before someone comes into the visit. And so we can maximize the amount of time a physician has with a patient and reduce the amount of sort of post-care, post-visit charting work that has to be done. And we can't do it all, but we've certainly had an eye on making sure that we preserve that physician-patient connection to the greatest extent possible.
Right. Um, I've seen a lot of people have commented on how one of the most valuable things that technology can do, or technology that physicians identify as the most valuable, is the technology that makes itself invisible, whether that be something that, you know, provides better information about which patients need to be seen, or ambient listening solutions where you don't have to take notes. People don't want to interact with their computers, they want to interact with patients. And I think that's so important, especially in the healing art. You need to interact with people. Humanity and that connection can't be replicated. And technology has kind of stood in the way of that. And some of it's cost prohibitive. So we spoke a little earlier about that and what it means for rural health. And I really liked what you said, that rural health, that's the backbone of our society, and that's so important. I don't think everybody who knows about healthcare technology really can grasp like the cost of switching systems or any of that, why their data doesn't go back and forth. So I thought maybe you could comment on that.
Sure. Yeah, interoperability is a significant challenge, and it's not a technological challenge. It's a political and a business challenge. And there's competing business interests at play that have prevented the exchange of data. HIPAA transaction sets have been around since late 90s, and so we've defined the format and the methods by which to transmit data, and yet we still can't. And I mentioned to you before this meeting, I was talking to an analyst, and the analyst had to see a satellite hospital and asked why her electronic records weren't shared across primary hospital and the satellite hospital that were in the same network, same organization. And it was because the effort had to be stalled because it was going to cost $45 million. And it shouldn't cost $45 million for a community hospital to be connected with a major tertiary center, particularly if they're in the same organization. That is a significant barrier. And so you can only imagine how difficult it is for community and rural hospitals that may have fewer than 100 beds, small population size. They just don't have access to many technologies. They can't afford it. And that puts patient lives at risk. And so, we've worked specifically with community and rural hospitals to create kind of a shared services solution with Quorum Health Resources, who serves those rural hospitals, just because we know they are the safety net, and it shouldn't have to be so expensive. And I'm very hopeful with Mickey Tripathi, serving now at the federal level. I mean, there's a keen recognition of the need for interoperability, and I hope there's going to be a focus on breaking down some of those barriers, because the only people that are losing out are patients by not being able to transmit their data. And it
Yeah.
should be a patient right to have access to their medical record and have that portable. Spain has had interoperability for a long time, and there's no reason in the United States that we shouldn't have it, and that competing business interests are preventing it.
Yeah. I actually I love interoperability. I think it's so important. I also think it's not just the patient that loses out, it's also like society. We have real barriers. I know in some areas, when you're dealing with um, addiction problems and patients, people who are trying to get medication, it's hard to have that communication and that trust when you don't have transparency. Um, and that goes both ways, like whether it be someone who isn't able to get the support they need, or someone who's trying to take advantage of a system that doesn't communicate back and forth. In interoperability, it's interesting because I've also seen data breaches that are pretty substantial with with moving patient data back and forth. Um, and so I really like, I mean, I think it's so important, and I'm glad that, aren't they releasing the new rules soon, like with the how people are going to handle that. So it'll be great to see how that improves. I We talk a lot about like competing business interests and technology. Um, I know a lot of the people at like big HR companies who want to improve healthcare and want to improve physician lives. What do you see as like the potential or the next step? Like, would it be building generation two? Would it be these regulations and funding that enables data transfer, or something else?
Yeah, I think it's to expect that every AHR can be everything is too much to expect. I mean, there's a reason why there's specialty apps. You brought up sort of ambient listening, right? Sequeira is a great example of an organization that can handle ambient listening and translate, sort of physician dialogue into notes automatically.
Right.
To
I think they're
expect that it,
Nuance now. They got acquired.
yeah, well, yeah,
Good job,
and
Nuance.
but to expect that an EHR is going to do that, they're going to be able to handle, multimodal communication and run outbound education campaigns. And it's just too much. There is a specific need for an EHR. And then there's a need for other wrapper systems to enhance that EHR. And I think that that's a reasonable expectation. And to put all your eggs in one basket and expect that the EHR companies, and you may only have one or two that could ever pull it off, and it may take far too long to be able to do it, and they may not be able to innovate fast enough in a way that maybe sort of specialty or niche companies could do. So I think that I think that there's promise in, a number of specialty organizations that can serve different purposes. I think there's great promise in, from our perspective, right, we have data science teams that are working on, predicting a whole range of chronic conditions and exacerbation of disease. And so if we can get that in the hands of people so that we can prevent, diabetic complications, if we can prevent hypertension complications, if we can prevent admissions or readmissions, that's incredibly useful. If we can also provide information that shows maybe what's a right medium for an individual, and that we have telemedicine that now sticks as an opportunity, or we have a in-person at different locations, or we have remote monitoring. That's it's a wonderful complement of different vehicles. And Atrium is obviously such a leader in so many ways, but they've made it clear. I mean, they're addressing all the ways of interacting, whether it's telemedicine, whether it's remote monitoring, whether it's in an acute care setting, whether it's in a post-acute setting, an ambulatory setting. I mean, they're making sure that they're meeting people where they are, and they're using robust data to I think identify the needs of the population, the social determinants of the population, and helping to provide care teams that are addressing it holistically. And so I think we're at a tipping point now of really being able to, take in all that contextual information and care for people in a way that we hadn't been able to before. And I do think that there's payment systems that are aligning. It's just that, at the same time we get hit by COVID. And so we're 1 foot in emergency mode, right? And with a physician and care team, overall care team, all care professionals are burned out, they're struggling, they're exhausted, they're taxed. And I think that will maybe slow down some of our ability to move on to sort of the next iteration of healthcare that's coming. But I do see it coming. I feel very hopeful, and I'm just constantly amazed by the resiliency of the healthcare professionals, but I don't think we should be relying on their continued resiliency. I do think that we really need to address the challenges that they've been facing, the underlying sort of toxic stress that they've been experiencing, if we're going to help move into the future.
Yeah, I like that. I like the idea. Like, people say a lot of times, like, oh, you're strong, but really, if someone has to be strong, that means they're working in a system that is not functioning in the most ideal way. Recently, also, I had a conversation with someone about like what they would do to help. We talk a lot about, we need to help people. We need to make sure physicians have that quality time with patients. But I want to ask you, like, this is a personal question. You personally, like, if you could do like tomorrow, like snap your fingers and one thing was fixed, or you could help in one way, help physicians, what would you do? And the last person I asked, they were like, well, I would help with childcare. And she was like, she's a leader. She's awesome in business, period. And she has kids, but that's something that she saw as like what she would like to help with. What is something that obviously Jania does a lot. Like they help reduce the cost of care. They're helping get people the insights they need without expensive technology. But you personally, like, what would you do? What do you think if you could solve one problem or if you could work on one project? What would it be?
Oh, if I could do anything, I
I didn't warn her
would.
about this question, guys. This is the
Yeah,
surprise question. It's like my favorite question.
yeah. I would expand the amount of time that physicians have with patients, which means it means reducing many physicians, even if they're salaried, they are tied to an RVU calculation. And so it means reducing the number of RVUs that they have to generate on a particular day, week, month, year as part of their contract. It means letting up on that and looking differently at for folks that own physician practices, looking differently at revenue sources, thinking about diversifying those revenue sources so that you're maximizing your quality bonus programs, you're maximizing the money you can generate from care coordination activities, you can make up for those gaps. And but I think sometimes it's just easier to keep the physicians on the hamster wheel. So if I could, it would make so many clinical team members happy. It would make so many patients happier. I can't even imagine how much better coordination would occur. When you go in and a physician is able to take time with you, how different that experience is, and how many more problems are solved, and how much less confusion there is coming out. And so, if I could do anything, I'd change the amount of time, and which would be reducing then the RVUs that are expected from any given physician.
Oh, I love that. Like, so RVUs is for people who don't.
Relative value units.
Yeah,
So it's based on the coding and the amount of time they spend and the complexity, and
yeah,
so
yeah. People have talked about that a lot. Like, are you giving someone a super complex visit? I also notice my kid's pediatrician always spends enough time with them, and and I sought out a physician that I knew did that, and obviously his. I think he works long hours. I think he just works all the time to be able to give that great care. So if it was scheduled, that they would be able to do that and then be real people, which I'm sure he is, um, it would be incredible. Do you have any last thoughts? So this is what
uh,
I mean, I think it's great. Like your perspective about like measuring how things have been going and like the hopefulness is really important about how technology has the opportunity to build great things, but also yeah, like to me, it's super inspiring.
Thanks. Well, I appreciate all the work that you do, the work that you do with health IT companies. Certainly, the all the work that you've done on physician suicide, which is critical. But the scholarships that you're getting in the hands of new medical students, and now even the work that you're doing to provide for money for residents so that they can get childcare that they need. I'm just inspired by your work, and
It's
it's
crazy
always
that
a
they
pleasure
don't
to speak
have
with
a
you.
system for this. Like someone was sharing online, they're like, how is it that during COVID, when we're frontline workers, like no one cares? Um, and I think it's easy to look the other way when it's not something that you're directly responsible for. And I'm glad that there are people who decide not only to not look the other way, but are proactively seeking out ways that they can help. Because that gives a lot of hope for humanity in general. That like things are okay. Like we're gonna do okay, and hopefully the burden won't all be carried by nurses and physicians, and technology companies are caring about that and stepping up as well. So thank you today for
Thank
coming
you.
and talking to me. If anyone wants to know more, Heather is online. I'll include links to her information and to Jania. They have the Physician Misery Index, which I think is such a clever name too. Just measuring like, are you happy in your job? And what does that mean for physicians? And I think it's an important thing also for patients to see
Mhm.
how physicians are doing and what that means for them. And I really liked your comments too. Maybe we can add some more insights about alternative income streams for healthcare to enable physicians and others to be able to spend more time with patients and give better care. So thank you again. I'm going to
Thank
pause the
you.
recording.